I'm going to do something distinctly less sporty. That was certainly some sporty stuff, but this is very much not sporty. In fact, ankle fractures in patients with diabetes are a really vexing problem. And if you don't see it, again, to borrow what Manoli said, it's going to see you. And if you're not aware of it, it causes terrible problems. Standard techniques and implants lead to problems. This is not something you're going to do with, or maybe you are, with fibular rods and sutures. So learning objectives, I think you have to acquire suspicion for these injuries. And then once suspected, be able to use appropriate hardware and techniques. If one slips through, know how to salvage it before long-term problems occur. And if there are late problems, we want to salvage the limb. The goal here is not a return to sport. It's to be able to get up and go from your bed to the bathroom without having to put a prosthesis on. So I'm just going to start with a case example. This is a standard ER film, nothing too excited from the fracture pattern. Decent reduction, except for the lateral where it was displaced posteriorly. These were all done outside. Here's the standard ORIF, looks good. 12 months, still looks good. 27 months, oops. So these are insidious. One day they're doing great, and then a few months later, they're going to really ruin your day. So you have to be suspicious of diabetes and Charcot. Look at the body type. I've often diagnosed diabetes in patients who didn't know it, which I think for an orthopedist is pretty good because, you know, we're, as they used to say about us when we were residents, we were, what is it? Strong as an ox and half as smart, right? So you talk to the patient. Do you ever have tingles in your feet? Look at the patient, see what the BMI is in your head. You don't have to actually calculate it. But as Hansen used to say to us, if she were a little taller, she'd be spherical. You have to be suspicious about that. Have robust hardware available. Don't go into the OR with one-third tubular plates. It won't hold up. So even if you cycle these newer hardwares, anything cycled enough will fail. So my takeaway message before we get into it is go long and go strong. Here's a 45-year-old male. He has diabetes. He already has peripheral neuropathy. He had 1 month of ankle swelling. Saw his PMD, who said if he can walk, there can't be a fracture, so he didn't bother to get x-rays. And here are the presenting x-rays. You can see there's lateral subluxation in a standard kind of Weber B. Now I'm just kind of wondering if he has a syndesmosis also, Haji, I think maybe. So, you know, there are standard options. This is a very old way. This is probably the first fibular nail, the old boat nails, I guess. These were originally made in the shoulder, but a lot of people swung them upside down. I was never a big fan of this because I believe in rigid internal fixation. But you can predict what's going to happen, right? Because it's not locked. So here it is at 10 days. Here's the revision, kind of looks like Mike's case, right? Whether you do 3 or 4, what size screw, that's not really a controversy anymore, but you can see that this looks pretty good in the OR, and then you can see it's starting to slide out. So Manoli started thinking about this and developed a type of what we eventually called the ladder. And you want a lot of points of fixation. You want to get across the syndesmosis. He used non-locking screws because variable angle locking didn't really exist, but you want to aim them from the fibula into the tibia, and proximally, if you can't freehand them or have more freedom on your locking screws, you're going to miss posteriorly, right? And then they can back out. So the hardware does hold up. Use the biggest hardware you can find. This is from Art's original salvage of failed Charcot ankle, and he used the biggest screws he can and the biggest plates. And this, again, is not a suture solution. Here's a 60-year-old male. It's a low energy twisting injury. Again, very routine ankle fracture. Patient has diabetes, and he has what in my program, my residents call the Claire sign. This little fleck avulsion posteriorly clues them in that something is unstable, and they should take another look. So we did a lateral approach. We did sort of a distal and a proximal, slid the plate up, past the higher fracture. Here again, this is my version of what Haji was showing. I actually put a distractor in here, a lamina spreader, get the screws across, fix the medial side, and then put as many screws as I can. This was a non-variable angle plate. The variable angle plates do exist now, so it's kind of hard, especially as you get up top, to get the top screw across without missing posteriorly. Consider bone grafting these. If you have the bone graft, just put some in. And also, we started filling this area with bone graft. It's, as you know, very hard to get a syndesmosis to fuse, but if you kind of scuff it up, if you, instead of using that freer, the way it was shown, if you kind of put something in here that's going to bugger up the joint surface, although the incisura is not a joint, it does have sliding articular cartilage on it. And if you can get it to be a little adherent, that's all good in my book. Here's a 32-year-old morbidly obese female, again, BMI is spherical, many year history of insulin-dependent diabetes, nicest lady in the world, one of my favorite patients. She worked on her feet as a hotel chambermaid. She presented to her local orthopedist, who is one of my former residents, 6 weeks ago. She just twisted her ankle. She has minimal pain. The deformity was worsening, sorry. It's a closed injury. Your foot is warm. There is good circulation. Again, just because you're Charcot doesn't mean you have vascular problems. So they will heal if they have good inflow. So here is the presentation. Again, you might think this might be amenable to some nice suture button technique, but as you can see from her soft tissue profile, this might stress that repair a bit. So again, we did a ladder technique. She's now out to 6 years or more. She was working full time. She never went on disability. And she actually just retired and moved to upstate. So she's still doing well. For these, I delay weight bearing for 3 months. They decrease or have no protective sensation. I don't use casting because I want to look at the incision in the soft tissue. I put them in a well-padded 3-sided plaster splint, what euphemistically is called an AO splint, and then they go into a Velcro cam boot with a Velcro Knight 90-degree splint. I don't want early range of motion. Lack of range of motion, as you all know, is not a major concern. By a year, whether you hold them in a cast or you move them early, these are not athletes. You're getting back to play. I don't start early PT. I don't want the construct to break down. Yes, you can use an osteopenia protocol. That's always helpful, whether it's formal medication or just hormone D. And now I just learned from Jen, 600 BID of calcium. And if we can get the insurance to cover it, we also use a bone stem. So standard fractures cannot be treated in a standard fashion. These patients have no protective sensation and they will break everything down again and again. They stress the hardware until any hardware will and does break. It has to be addressed with extreme measures with respect to strength and rigidity. So in summary, ankle fractures, suspect them. They're not normal. They don't behave like that. We need different techniques. We need robust, rigid hardware, maintain a longer non-weight bearing period, be less aggressive with PT. Tight glucose control is helpful. Go long and go strong. And as Manolo used to say, you have to wait for it because here comes the boom in these fractures.